Well, thanks very much for coming, everybody. It's nice to see people from the community and friends and colleagues here. So, a few things just to get out of the way at the beginning. As Paula mentioned, I do better if you save your questions or comments or at the end. I know sometimes you want clarification as you go along, but I'd like to try and get through the material and be able to stay on focus because if I get distracted, I might go down some rabbit hole we won't get back. There is some information that I'm giving relates to some laws, and these laws are specific to Ontario. Some of the information specific to Ontario is different than what is specific in the other provinces, even though we're in the same country. And of course, if anything has a legal aspect to it, I would want you to get proper legal advice. I wouldn't want you to take my word for it. So even though the title of this slide is End of Life Decisions, we're going to be talking a lot more about things that are important to be thinking about or know about while we're actually alive before we get to that point. So even though it sounds like a little bit of a gloomy topic, it's important to face these things. I always feel better if I have a plan. I think I'll just give you a little bit of information about my background so you can see how I fit into this particular topic. So I started off in healthcare way back in the 70s, and I was a psychiatric nurse. And eventually I became a family doctor, and I had a side hustle of doing psychotherapy. But when I moved to Muskoka in the 80s, I restricted my practice to treating emotional and psychiatric disorders. And a number of years ago, I had the great good fortune of being able to be attached to the Hope Huntsville palliative care team with Dr. Deb Harold, and Norma Connolly, and the other wonderful people of the team. And that gave me a real close-up view of how important it is to be thinking about the wishes that you might have if you become ill, or even more seriously, if you have a life-limiting condition, and what a great job they do of assessing what people's wishes are and to help them make decisions at a very critical time in their lives. So that's one of the reasons that I have been interested in this field. So making your wishes count, and the emphasis is on the word your and wishes. So most of this talk is really going to be about the agency that you folks have in managing your own healthcare needs. It's always important. It's even a bit more critical right now because, as you understand, I'm sure have experienced, healthcare is having a bit of a moment of challenges. I think it's going to get better, but it's difficult right now. And it's really important that you all know what it is that you wish and be able to advocate for yourself. As you can imagine, a lot of my patient work is with people that were very marginalized. I don't think they even thought that they had a right to have an opinion. And so part of my job was trying to help people assess the kinds of things that they might need and might want, and be able to advocate for them in the greater system. So when we think about wishes, let's think about what are the things that might be involved in trying to narrow that down, to discern that. And so these are some elements of that we're going to talk about more tonight. So advanced care planning, substitute decision maker, and power of attorney for personal care. So why does all this even matter? Well, it matters because these things, the more that we have an assessment in our mind about what these things are and are able to speak about those and advocate for ourselves, the more likely it is that we will have our experience with the healthcare system in terms of being able to retain a sense of dignity. So what we know from doing lots of studies and research on people who have serious illnesses or at the end of their life is that some of the things that they fear are not even so much physical symptoms, but things like loss of autonomy, loss of independence, and loss of dignity, by whatever that means to that individual. Obviously, what we mean by dignity can change from person to person, and depending what stage of your life you are. So the more likely we are, the more that we consider our future needs and be able to express them and maybe hopefully achieve them, is the more likely that we'll be able to retain that sense of dignity, which is important. We're going to talk more about that in a second. So when you enter the healthcare system, ideally, you're a part of a healthcare team. And that healthcare team would consist of the medical side of things, and your side is the patient side of things. And what it aims to be is to be collaborative, meaning that you both have a say in what happens and you're working together, and that it's patient-centered. When I think back about when I started off in nursing way back in the early 70s, or late 60s actually, I mean, the doctors may have been very good and kind and well-meaning, but it was very paternalistic. Nobody ever considered what the patient might want. It was more or less a treatment plan was, well, it wasn't even more than suggested. It was kind of presented as, this is what you do. And you either did those things or you just went away. And there were things that you experienced where patients were not even considered as themselves as a person particularly, but more like their disease, like the gallbladder in room 302. Anybody who's worked in a hospital back then would remember that. And that's one of the reasons I probably ended up in psychiatry, because even though there was lots of flaws in that discipline, at least they were talking to the patients. So over the decades since then, things have really evolved. And although it's nowhere near perfect, I think we're aiming much more towards being considerate of what the patient might want and what their wishes and beliefs and values might be in terms of making their own decisions. So on my side of things, the medical side of things, we have specialized knowledge in what's going on with you, hopefully, but you have specialized knowledge in yourself. And those two things should be integrated as much as possible. I think it can feel, I'm sure some of you experienced it or with people that you are supporting, of feeling like when you enter the healthcare system, you kind of get on a conveyor belt and you're going along, if you've got something significant, and people on either side of the conveyor belt are doing things to you, and you more or less feel like you're stuck there as you go along that conveyor belt until either you fall off or you get to the checkout counter, I guess, at the end. And it really doesn't have to be that way. It shouldn't be that way. It should be that all the way along the line, where there are people that are suggesting things, that you have a say, you get the right information, and that you have a say in what it is that you would wish for. And I use the word wish because we don't always get what we wish for, but at least that there's some kind of collaboration in terms of the discussions about this. So let's talk a little bit about the whole aspect of dignity. So you've all heard that expression, dying with dignity. Well, what does that really mean, actually? And I think it's pretty difficult to have an end-of-life experience with dignity if you haven't had a life lived with dignity. So I think the elements of dignity would be things like being treated as a whole person, mind, body, and spirit, and dealt with kindness, respect, and compassion. There's a concept called personhood, and that refers to our essential worth just because we exist. Our worth is not dependent on things like our status or our gender or our sexual orientation or our cognitive capacity or our culture or a religious tradition. It is a basic element of our existence. And that needs to be honored all the way from birth to death. And, even if the other side that we're dealing with is not thinking about us in that way, it's really important that we do, because it's from that place of strength that we can move forward and, speak for ourselves. So, I mean, obviously, there are that when we wish for things, there are constraints of things that are not possible. But I have a philosophy that we should always start with 100% of what we would wish for. We aren't demanding it, but we can start from that point and go from there, depending on the reality of the situation. So, if our wishes and sense of dignity and so forth, they involve these factors of personhood, of being treated and seen as a whole person, and the elements of respect, kindness, and compassion. And it obviously goes both ways. If I wish to be treated with dignity and respect, then I am going to be doing that in the other direction, hopefully. So thinking the difference between how medicine was practiced way back when I started and now does give us all a higher degree of responsibility. And on my side of it, my responsibility is, if you come to me with the condition, is to help you figure out what's going on with your symptoms and talk to you about what testing might be necessary, as well as the fact that it's not a situation where more tests deliver better results. Sometimes more testing is actually problematic. And talk to you about what the nature of this condition is that we think is going on, as well as what treatments are possible, what outcome we would hope to get from those treatments, what the downsides of the treatments are, because there's no free lunch, there's always downsides to things. What would happen if you don't do the treatment, or if you're on a treatment to stop it, because that is often one of the decisions that can be made. And what the trajectory is what will I expect to be happening with what I have? Is it going to go away? Is it going to stabilize? Is it progressive? And if there's an idea about the rate of progression. These are all things that would be very important for me to be explaining to my patients about whatever it is that they've got. And on the other side, you then have a responsibility to get this information, clarify things, learn as much as you can about whatever is going on, find out about what resources. You might have to knock on the door quite a few times to get this to happen, of course, but it is important to speak up in your own behalf, and to know what it is that you value and wish as it relates to these healthcare decisions. On the medical side of things, it is our job to present to you the standards of care, whatever is the state of the art and with whatever we're dealing with. But that might not work for you. There may be more nuanced for you as to what of that plate full of goodies that I have to offer you is going to suit you. And you have a right to decline certain kinds of treatments if you want it, after discussion, obviously. So the idea is not just to accept what is presented to you as the treatment options, but to integrate that with what are the things that are important to you. And hopefully there can be dialogue with somebody about that to help you through those kinds of decisions. So one of the ways that we start to figure out or narrow down what our wishes are is what's called advanced care planning. So more or less what it sounds like is that on behalf of my future self, I am thinking about what my healthcare needs might be and how I might want to handle various contingencies as they come along. And so that would include these elements of what our wishes are and what our preferences are. I may wish for different things depending on my age or my circumstance. What are my preferences? Maybe where I would want to have, if I had a serious illness and maybe I'm close to the end of my life, where would I like to be? Maybe I want to be at home. Maybe I'd like to be at hospice. What my wishes are for how to be treated what kinds of treatments I might want. Like, for example, if I'm an elderly person and I have a bad cancer diagnosis and I've got other medical conditions, and I may be offered another round of chemotherapy, I might say that my wish really is to spend the rest of my days at home with my cat maybe and my friends around and have supportive symptom control through the palliative care team. But I might think something differently entirely if I was a young woman with dependent children. I might be prepared to have any sort of treatment that I could tolerate so that I could have as many possible days with my kids as I could. So another part of advanced care planning is the whole area of substitute decision-making and powers of attorney. And I'm going to talk about those things a bit more, because it's not just enough that we know what we want, that we've sort of thought that through, but that somebody else knows that. Because sooner or later, to all of us, we are not going to be able to speak for ourselves. So we need to have somebody else be our advocates and speak for us when it comes time to have decisions made that we no longer have the capacity to make. It's also the responsibility of the patient to, get informed and to stay informed as things evolve. What you hear at a first appointment is going to be very different as time goes on. And the communication piece, you want to be communicating to everybody. You want to have conversations with your healthcare people. You want to have conversations with your supportive people who are supporting you and with your substitute decision makers. So what's a way to go about that? And let's just move to that slide. So advanced care planning. This is a really good website. These resources, Paula has some sheets available for you there, and I have a slide at the end. So if you go to this website, Advanced Care Planning Ontario, and I suggest that you look for the Ontario one. There's an Advanced Care Planning Canada, but this is specific to the laws of our province, so you'll just get more accurate information there. It's important to do these things sooner rather than later, because you don't want to make these decisions in a crisis. You want to have a chance to think through these things before, so that you can plan ahead. So I've got an example of the workbook. Let's put that down. So if you go on the website, you will find somewhere in the information, there's a lot of good information, Advanced Care Planning Workbook, and you can do it online and print it off, or you can get a hard copy like this. This is put out by the Hospice Palliative Care Ontario. And in here, you would be able to, in here or on the online, is to go through some exercises in figuring out some of these specific things. So there are questions for your healthcare provider. More or less what I was explaining is what would be my job to provide for you. If you don't get that information, you can ask for it, and you should get that information from somebody who is aware of what your issues are medically. And then there's a spot that's called the values exercise. And that leads you through thinking about what it is that you value. What are the things that are your priorities that line up with your preferences and your beliefs? And obviously, you're going to try and get this information for your substitute decision maker. This can be in this book, actually, or on the online. There's a space to write all this down so that you can have something written for them. It's not any kind of legal document. It's just a written information for your substitute decision maker. So when you came in, you got the opportunity to pick up a card. And that is an actual game called Go Wish. So you might never want to come to a games night at my house, because I'm going to suggest we play the dying game. So, but it's not necessarily about dying. It's more or less about your future wishes. And how the actual game works is you would be dealing out these cards, and people would get a hand of cards, and you ask people to pick out what would be the most important things, moderately important, and things that are less important. And then what you do is with the things that are most important, you would talk about them with each other and see if people were going to think differently. And then importantly, you'd figure out, okay, if this is really important to me, how will I get that to happen? So just to give you an example, I just picked a card at random out of there. And my card says, to know how my body will change. So if that was me and I had some early stage of some condition, let's say, a lung condition, say, I want to have a sense of what's going to happen so that I can think ahead. So let's suppose I'm going to find out that I've got, emphysema, say, and over time I might need oxygen, I might have less mobility. I'm going to be thinking, okay, I live in a house in the country, I have to do chores around the house. Maybe I need to be thinking ahead right now while I am relatively well about what I should be doing next. So maybe that's when I would be thinking, maybe I should think about, assisted living, like a retirement home, or maybe I should be thinking about living and moving to the town and having a condo. What kinds of supports would I need in my house? Do I need to make my house more accessible? So those would be very practical and tangible things about if I had a sense of what is going to happen to me as time goes on. And then obviously there's the whole psychological aspects of it, that we anticipate these losses and face them in advance, even though it's hard to do, because that prepares us for things as they come along. It doesn't make it okay, but it makes life much more tolerable if we are ready for things. So how anybody who feels comfortable, could you just stand up and shout out your card? And we'll just see, these are examples of wishes that people have had over time. Sure.
To prevent arguments by making sure my family knows what I want.
Good. To prevent arguments, to make sure my family knows what I want. Anybody else? Speak out of their card? Anybody? Yeah, go ahead.
To have an advocate who knows my values and priorities.
Yeah, good.
Be at peace with God.
To be at peace with God. Okay. Mm-hmm.
To be able to talk about what scares me.
Mm-hmm.
To have my financial affairs in order.
To have my financial affairs in order. Yes. To have human touch.
To have someone who will listen to me.
Yeah, have someone who will listen to me. Yes.
To have my family prepared for my death.
To have my family prepared for my death. To have close friends near.
To be treated the way I want.
To be treated the way I want. Yes.
Not dying alone.
Not dying alone. Yeah.
Not being connected
Not being connected to
to machines.
machines. Yeah, that's a good one. Yeah. Yeah. So think about, whatever it is that's on your card, which obviously is not the last word in things, is think about, okay, if I'm starting now and anticipating ahead to, should I get a serious illness or towards the end of my life, what will I do now that can aim for that? I was talking today with somebody who's in a sort of palliative situation, and their wish was one of their wishes is to have family around. And you can't start now, if I'm got a serious diagnosis, I can't start now having a close family relationship. And it doesn't have to be biologic family, it can be chosen family of people, is that is start to cultivate your relationships earlier. So if you don't want to die alone, you need to have people around now so that you have those connections. Let's see here. So what if the circumstance comes, I didn't say what if, because at some point we can't speak for ourselves. That's going to happen. The elements in that are substitute decision maker, and I'm going to talk about what that means, the substitute decision maker hierarchy, and powers of attorney for personal care. So a substitute decision maker is someone who is making decisions on your behalf. They are substituting for you on your behalf if you cannot speak for yourself. So the things that a substitute decision maker can and can't do is they are consenting or declining treatments that are being offered to you. So they don't come up with a plan of care or treatment ideas. They are to represent your wishes, not their wishes. They are to accept or decline treatments based on what you have told them you would like. And that's why informing your substitute decision maker and being very clear about what you might and might not want is really important early on. So they do not make decisions based on finances. It's only healthcare, things like healthcare treatment plans and options, and things like if there's a recommendation that you move to long-term care, they can consent to that. They do not consent to anything to do with your money or property. That is a different power of attorney. There is a power of attorney for that, and that's called power of attorney for property. So the substitute decision maker is a very important person in your planning because they are your voice when you do not have your own voice. So the Healthcare Consent Act lays out a hierarchy of these substitute decision makers. And I'll just give you a scenario. Imagine somebody's in the hospital and they are unconscious. Either they've had an accident or a medical situation in which they have lost capacity to consent for themselves. The medical people are going to go look for somebody to consent. Now, there's lots of situations in which consent is assumed, but if there's time to be thinking about it, they're going to want to have somebody who is going to consent to the treatment options. So you remember me talking to you about what informed consent is. In order to do something to you, they need to have consent from somebody. And if you can't speak for yourself, somebody else needs to be there. So the hierarchy has been laid out by the Healthcare Consent Act, and there's 8 or 9 levels depending on how you look at it. And the top level is a court-appointed guardian. Those are not circumstances we would see very much. The next level, which generally ranks the highest in practical terms, is the power of attorney for personal care. And then then there's a category to do with if the Consent and Capacity Board actually nominates somebody. But again, it's not something that we see very often. Those 3 top categories are the legal aspects. So there's actual legal documents to those 3 top ranking in the hierarchy. And then comes your spouse or partner. And that does not have to be, you don't have to be legally married. It could be a common law situation. It could be same-sex relationship. Has to have been established for more than a year. And it can also be a permanent living partner. So you might be sharing a home with somebody, and that's a permanent arrangement, not just sort of a random boarder, but somebody that you've had a strong connection with, and you've got a committed living situation. And then comes paired children, and children. And then the next level is if there's a child custody situation where one parent only has access, and then it's siblings, and then other relatives, and then last group is the I always forget what it's called. I've got this down here. Okay, here we are, is the public guardian trustee. Just go back here. So if you're in a situation like I was describing, that scenario where somebody can't speak for themselves, they are going to go look for this next person who's on the line in the hierarchy. And something that I think is really important is to actually name somebody as your power of attorney. And the reason for that is that you may not necessarily want the person that's next in line in the substitute decision maker to actually be the person who's going to speak for you. You know, there might be, even if the next person was your spouse, who you may trust, you might think, well, maybe this is a bit too much for them and they are not going to want that responsibility. Maybe they've got their own health conditions. Maybe if it goes to the next level of, let's say, your children, if you have 4 children, they all rank equally. So it doesn't go by age. So all 4 children would have to agree unless they agreed to name one person as the representative. And the same thing for siblings, they rank equally. If you've got adult children and parents, they rank equally. So I think it's a good idea to think carefully about who you might want as your power of attorney and actually name that person and make a document. It's not something you can just do verbally. It has to be written. I mean, obviously you can do it with a lawyer. I'm usually in favor of that kind of thing, but it is something you can do yourself in writing with 2 independent witnesses. Obviously aren't the power of attorneys, that you're all signing things at the same time. And that people know where that document is, and obviously that whoever you name knows what it is that you're asking of them, and that they know what it is that you want. So planning ahead is not just about end of life, clearly. I mean, we have, you know, we're front end loaded. We have more life before we have the dying part of it. And, you know, in fact, as this little slide says, we've been dying since we got here. So we have to remember to think about living our life with purpose and meaning and doing whatever we can to invest in our future selves when we can. When we're younger, it doesn't matter when you start, is that you think, okay, in what state do I want to be think about my future self 5, 10, 15 years down the road, and to begin to think about that and what our well-being and priorities are now so that we can achieve those things down the road. I think I've got something else here I wanted to make sure I covered. I got that one. Yeah, I think I got that. So planning is not just for health. So these are my 2 lovely dogs. I don't have dependent children at home, but I have to be thinking about the disposition of all my belongings and so forth. And I have an idea for you that I found helpful, and that is, this is my show and tell, that this is a binder of everything that you would need to know about me if I was incapacitated or died. I was thinking about that when I was coming in here because there was a big lightning strike, and I thought, this is really good advanced planning, because here I am, I've died in the parking lot, and I have all my information right here. So in my book here, this is what I have in mind, is, you know, all my general demographic information, you know, OHIP number and so forth, my important contacts that I would want to be informed, my banking, investment information, insurances, passwords. That's something people forget, is we all have passwords to our banking and computers now, or some of us do, all the details of our powers of attorney and our will and my will and where those things are in my house, and my advanced care wishes, which I've just gone through. I've gone through the exercise just like I talked to you, and all the things I would want and not want should I have some serious illness that requires that intervention. And included in my advanced care wishes is what I would want to happen with my dogs. And my funeral wishes, what I would, what are the kinds of things that I would want. So that way, anybody who, my executor and power of attorney, if they are going to be upset at the time, and that way they don't have to struggle with figuring everything out at a time when it's very difficult to manage even kind of day-to-day life, probably. So we're considering all of these things on behalf of our future self. So we hear about advance directives and living wills and advance requests for assisted dying. So advance directives and living wills, these words are not mentioned at all in the Ontario law, and we do not have them in Ontario. You can write things down about what you would like, but it's not any kind of a legal document. It is just for information and a guideline for the people that are going to be speaking for you. And of course, the things that we've been talking about tonight are wishes. They are not directives. They're things that we would wish for, which, given the reality of life, may not be possible, but I always think it's a good place to start. And so I was at a talk last year, and most of the audience questions were about this next topic, about advance requests for assisted dying. So I'm going to spend a little bit of time and talk to you about that. So just a little bit of background. So this is to do with medical assistance in dying, which has been legal in Canada since 2016. And in 2021, there was a new iteration of the law. And a couple of extra things were proposed, and one was which you probably saw a lot on the news about, was allowing MAID for mental disorders if that was the sole underlying condition. And that's been tabled and probably will, I would think, would disappear. I don't think that'll ever happen, or at least not for a long time. The other one, which is one of the most popular requests of having in the MAID legislation, is that you could have an advanced request for assisted dying under some circumstances. So basically, what this would be is that you could give advance consent on behalf of your future self if certain conditions were met, certain criteria were met, at the time when you did not have capacity to consent then. So as it is now, you have to be able to consent at the time of the actual MAID provision. And there are people who feel that that is too restrictive because they think ahead about circumstances under which they would have wanted assisted dying, but will have lost capacity so they couldn't consent. So, for example, somebody who, say, has a early Alzheimer diagnosis and is worried that 10 years down the road, they might want to be in a situation where they would have wanted MAID, but they would not have capacity to consent, so they wouldn't be able to have it. So if this law was passed, you would be able to, in some way or other, have an advanced consent for that under certain circumstances when those criteria were met. In Quebec is about a year ahead in the legislation, and they've already passed that law, but it's not enacted because they're trying to figure out how to operationalize it, because there's many, many, many complications in terms of actually making that happen. They are going to restrict their law to neurocognitive conditions like dementia. There is a big movement of people who are promoting this to open that up so that it could be for any condition, that any condition down the road that you might have wanted made, but you don't have capacity, that you could have it regardless of whether you started out with that particular diagnosis or not. One of the things that I think, so we're talking about the whole MAID topic, is just it gives me a chance to, I am on the MAID team, so obviously I am, I don't know if I should say I'm a promoter of MAID, but I accept the fact that MAID is a legal option that we have. I think it's really important not to see it in a kind of a dualistic way that people's deaths are either full of suffering or they have MAID, that it's only one or the other, that there are many, many interventions physically, psychologically, every other way that allows people's natural death to occur from their condition without MAID. So I just wanted to make sure that people understand that now that we have that option, that it is only one of the many options, including many medical interventions, social supports for families, residential hospice, and so forth. So Paula, I'm going to ask Paula, because I'm getting hoarse here, to just read this little poem.
Come to the mic and read it. Mm-hmm. When it's over, I want to say all my life, I was a bride married to amazement. I was the bridegroom taking the world into my arms. When it's over, I don't want to wonder if I have made of my life something particular and real. I don't want to find myself sighing and frightened or full of argument. I don't want to end up simply having visited this world.
That's Mary Oliver. So, and I would really like to thank you, Paula. She does all the event planning for all the educational team, and she, organizes rounds, organizes everything. She's and just quietly doing things in the background. She's terrific. So here's resources, and Paula has printed out this slide for you. So there's some excellent websites here about advanced care planning, dying with dignity. Hospice Palliative Care Ontario has a good website. The whole topic of dignity is dignity in care is Dr. Koshinoff's work in Winnipeg. We did a project of his here at our local hospice. And in terms of books, you may have known about Yvonne Heath's book, she's a local person, written a few years ago, but it has relevant information. This is a really good book, which I highly recommend, called Hope for the Best, Plan for the Rest, 7 Keys for Navigating a Life-Changing Diagnosis. So if you or anybody that you're supporting find yourself in that situation, I would really recommend it. It's written for the public. The 2 doctors are palliative care doctors, and they have a really good podcast called The Waiting Room Revolution. And in this book, I mean, it's a bit of I found it, a bit moving to read, because they are talking about real people in real situations and how you get information, how you speak for yourself, and how you get the support that you need, and find a way to navigate a very difficult time in your life. So that is the end of my slideshow here. And I'm happy to answer any questions or clarify anything. And we could play the dying game some more. Yes.
My question is around the DNR orders.
Okay.
So if you have a situation where you have cardiac arrest, you're non-responsive, but you don't have your DNR papers with you when the ambulance comes, how does that work?
Yeah. So a do not resuscitate order is, again, a legal document that you do with your doctor. And it states that if there is a circumstance in which resuscitation would be attempted that you don't wish it. So there would be somebody in a situation, let's say they've got a advanced condition and they are at home and something untoward suddenly happens to them and somebody in the family calls 911, the emergency responders are obligated to try and resuscitate you, unless you have that document, which you would keep on the fridge or at hand that you could show them, and then they will not put you through that. So I'm sorry, I was supposed to repeat the question. The question was, how does a DNR work? Is that more or less the question? Yeah. So something I didn't mention was part of doing all of this, I've seen you guys talking to each other. Do you want to say something?
I was just gonna say, if you have a DNR, you can make copies of it and travel with it. Because I think your question was, what if you don't have the exact paper?
Oh, okay, I missed that part. Yeah.
You need the exact paper. You need legal documents.
So, no.
You need the Ontario legal documents to be with you, or 911 responders to not perform.
Yeah, having a tattoo doesn't work either.
Photocopy verified. They all have a self-identified number at the top. Copies of that.
So for the people who don't know, that's Dr. Harold, who's the lead physician of the palliative care team, so we believe what she says. Yes?
Do you need a lawyer to do not resuscitate?
No, you have to do it with a physician. Yeah, or a nurse. So one of the things, that just sort of from that question that I didn't really talk about is some of the kinds of things that people do ask was, should I have a DNR if I have a life-limiting illness? What heroic measures would I want or not want? These are questions that people have asked us. If I'm dying, where might I want that to happen? What would provide me with the highest quality of life given my own particular circumstances? So those were just some extra things. Yes?
One of your resources was the Dying with Dignity. I've joined that organization. They just had an online petition go to the Canadian government with 16,000 signatures on it, asking for the advanced planning to be incorporated into the MAID.
So the Dying with Dignity is a group, and they have been supporters of the MAID legislation. And Senator Wallen is very big lobbyist for advanced requests for assisted dying. And that's something that that group really wants to have happen. It's a complicated issue, though.
It needs support, so if anybody's interested, they can go and
Yeah.
sign up.
Yes.
Could you elaborate on the heroic measures?
Yeah.
Like, all I can think of maybe is like feeding tubes and things like that. How does one explain that to the family, and what actually are those heroic measures?
Yeah.
To say you don't want it in precise terms, not can you put it in precise?
Yes, you can. I mean, again, it's not anything legal, not like a legal document. I can read you what I've got on mine, if that would help. Given that I'm 75, so these are my wishes. I'm happy to share them with you. So I don't want to be resuscitated in the event of a serious cardiac or pulmonary arrest that's not witnessed. I don't want extreme measures such as intubation, ventilation, dialysis in the event of an irreversible condition such as a massive stroke or severe sepsis or I'm in a terminal state. I don't wish tube feeding in the event of not being able to swallow or having no interest in eating if in situations if I had dementia or a serious neurological degenerative condition. I don't know about this one exactly. I don't wish treatment for pneumonia if I happen to be in an end stage state or if I have advanced dementia. And I said, if I'm terminal, I want to go to Grace Hospice. And so, certain things about, I don't want any of my relatives have to care for me. I want to go to retirement home or long-term care. So, I mean, and I had a specific one during COVID where we thought we might be in a situation where you had to make those. So, if in that, I believe in that website, it goes through what would be so-called what you might consider heroic measures. Now, lots of people would want all those things. It's not a question of right or wrong. It's a question of what would suit you in a particular contingency. And it doesn't mean that is actually going to happen. Just because, I've said those things, there might be circumstances in which it would make sense to do some of those things. Does that help? Yeah. Yes, Dr. Harold. What do you want at end of life?
Well, I thought you were going to say whether you wanted Dr. Harold.
Yeah. Well, that went without saying.
Right then. I was going to say, though, that one of the most the highlight thing that you shared with us during your presentation, actually, is really putting words to the obligation of the healthcare professional to be collaborative in those conversations. So, as valuable as everything that you just said about I wouldn't want, I wouldn't want, I would want, I wouldn't want, I would want, it all is I would want, but it depends. It depends on that whole conversation about in this moment for Pam, with what Pam has, if we gave her oxygen support in this form, there is a strong likelihood she will walk out the door and take her dogs for a walk next week because this is pneumonia that she can get through. Versus, she had a bad stroke and she's needing to be on these life support things, and there is no likelihood that she will walk out this door and she will be dependent on care that she would want or she would want. And there's where the substitute decision maker is making those decisions. But it really behooves us as substitute decision makers for people or advocates for ourselves to ask the tough questions of those healthcare providers. They're going to say, your oxygen is low, we put them on this breathing machine. It is that simple, right? That is the answer. But it doesn't necessarily make it the right answer. And you have to push us to say, well, what is the likelihood that this is going to happen? How long will this last? What does a trial look like? What is she feeling during this? Is she suffering during this? Et cetera, et cetera. All those questions. We owe you those answers, and sometimes it makes us uncomfortable to have those conversations, so we don't necessarily have them straight away, but that we ask the questions, but you deserve all of those answers. So make sure that we meet you halfway in that collaborative relationship.
Yeah. As I was saying, you're going to be presented with the state-of-the-art standard care, but it may not work for you. And that is what Dr. Harold is saying, is that, insist on these conversations and have their questions ready. Yes.
Just going back to the DNR and having the original on your person, does it have to be the original size? And I often will go just for a walk and not be carrying my purse or, like I'll carry my cell phone, and could I reduce the sheet and put it in with my cell phone, not on it?
I don't know.
Basically, yes. I mean, there are very, very few true emergencies in medicine. True life and death emergencies. And when I give this talk, I say, there are seconds between, should I do CPR, should I not? Anyone, quickly tell me what the right answer is. That's a true emergency. Should I hang antibiotics? Should we ask the surgeon to come and see this person? Those take time anyway, so we have time to find the person to advocate for you, right, if you can't say it for yourself. I drop dead right here. Do we start CPR? Is an emergency situation that I have to decide right now what do I do? And I'm always going to decide to try to save your life until somebody can show me evidence of some sort that she didn't want me to do this. Okay. walking by, no, like, she's always told me, make sure I hand this to you, and it's like a miniature copy of it, I'd like, I respectfully say, that's very important to her, she brought the actual copy of the paper, like, and even if you put it at home, like, picture, I think you have most of us very respectful of that legal document, and a picture of it, I know that's you, and I would respect that.
Yeah, these DNRs are numbered, so it looks like a pretty official document, actually. So, yeah.
Yeah, right now I carry the number with me, but not the document.
Mhm.
I would carry it, make the miniature, but yeah, that's the one.
If anybody has a question, I can stay at the end too. If you wanted to ask me a question just yourself, yeah. So, I think we'll wind this up, and thank you very much for coming. And I'll hang around for a bit if anybody has any questions. And yes, if you can keep those little cards if you want. If not, just put them back on the table, and then I'm ready for games night.